Just so that you don't miss Dr. Lawler too much, I've gone ahead and maintained his movie poster theme. And so we're going to talk a little bit about influenza and how we need to be preparing for that in the era of COVID-19. For those of you who did tune into the NETEC webinar last week, I apologize. A lot of this will be redundant. There's a little bit of new material, but most of it was covered in last week's webinar. And if you want to zone out for 10 minutes and come back, that would be advisable. Okay, so what I want to get across initially is that last year's flu season was essentially non-existent. As you can see in that arrow on the right-hand side, that was the 2020-21 season, and we never got ILI, influenza-like illness, above baseline. Nobody really knows completely why that was the case. We hypothesized that that might be due to some of the non-pharmacologic measures that were in place to prevent COVID, the distancing and the masking and the various things that were put into place. I would also be the first one to note that there's a lot about the viral dynamics with SARS-CoV-2 and human populations that we don't fully understand, and why this virus was able to completely crowd out all other respiratory viruses is really something that's quite interesting and not fully explained. The other thing that I don't think I need to talk to this audience about, but nonetheless should be again emphasized in our public conversation, is that our ability to sustain an influx of patients, whether that's due to influenza or anything else right now, is fairly limited. You can see on the right-hand portion of this slide a map from the American Hospital Association showing hospital census and capacity. And there's an awful lot of red, orange, and yellow showing that our hospitals are pretty full. And on the left-hand side of this graph is the dashboard screen cut from Douglas County, showing that the hospitals in Douglas County are running at about 90% census. So there's not a whole lot of empty beds. And as has been brought up in this call in past weeks, about 25% of all patients in our ICUs across the state are COVID patients. So we really have a lack of capacity to take on additional surge. Now, we're also worried about COVID-19 continuing to increase along with influenza. And some of the reasons why we might see COVID-19 spike in the coming weeks is that people are really fatigued about this. And so they've relaxed their mask and isolation and distancing precautions. We have more indoor activities coming up with Thanksgiving and then the end of year holidays with the attendant travel and family gatherings, et cetera. And potentially the waning immunity from previous infection or from vaccination that may be tapering off. And therefore, it's just completely imperative that we really try to get the population vaccinated for influenza. In addition, flu and SARS-CoV-2 can coexist together. Now, this is data from primarily 2020, large meta-analysis that was done, showing that, again, co-infection with these two pathogens is certainly possible. And you'll see it ranged anywhere from certain studies with almost zero co-infection to a study with almost 50% of the persons being co-infected. So the truth lies somewhere in between. And the bottom line is that you can clearly have patients who are co-infected with both pathogens. There's some data to suggest in those patients that they fare worse, as I think is somewhat intuitive. Now, the other thing to point out is that SARS-CoV-2 has had a big impact upon just vaccination in general. And so this is data from the CDC showing that routine childhood vaccination really fell down during 2020, as I guess is somewhat explainable by everybody just trying to stay away from healthcare in general. And so parents were not taking their kids in to get them vaccinated. I do have some concerns as well that the backlash against COVID-19 vaccination may spill over into our other vaccination efforts besides childhood vaccination. And we may see that some adults who had taken flu vaccine in the past may now decide that they just don't want to accept any vaccine, which would be very unfortunate. A lot of people ask when's the best time to get a flu vaccine. Right now is a perfect time. So anytime between about mid-October and mid-November, I think is appropriate. You can see in this graph from the CDC showing when the peak of the seasonal flu epidemics generally hit the United States. And typically this is in January and February, with February being the peak month. And so what people need to understand is that it takes about 2 weeks from the time that they get a vaccine to when they develop protective immunity, that tends to peak at about 6 to 8 weeks and sort of taper off at that point, about a 7 to 10% decline in vaccine effectiveness per month. And so again, occasionally we get a very early season, so people need to take that into account. Occasionally it goes well into the spring. And so again, vaccination sometime in the fall, mid-October to mid-November is typically when we recommend folks get vaccinated. A lot of people do have, complaints about the effectiveness of the flu vaccine. On any given year, it's variable a little bit, depends upon the match between the vaccine strains and the circulating strains in the community. But overall, 50% is a reasonable number to cite to people for vaccine effectiveness. And it quite clearly is worth our while to do this. And so this is data compiled, again, showing the impact of influenza vaccination in a season when the flu vaccine was not all that effective, about a 39% overall effectiveness rate. But what you can see here is that even with that fairly low effectiveness rate, 7.5 million infections averted, 100,000 hospitalizations, and over 6,000 deaths. So this is clearly the best tool that we have in the toolbox and quite well worth our society's efforts to get people vaccinated, which again, this season is even more important as we face both COVID-19 and influenza. Now, last year, when I gave some talks on influenza vaccine, there was actually a lot of concern as to whether vaccination would make COVID-19 worse. And so there were a couple studies out, one that was, I believe, out of Canada that showed in people who had been vaccinated that they were more likely to get non-SARS-CoV-2 coronavirus infections. And so people kind of extrapolated from that and they said, hey, let's not give people flu vaccine because you might be more likely to get SARS-CoV-2. Subsequent to that, there are now, I think, very good data to suggest that that's really not the case. And that at least there's a good suggestion that getting flu vaccine actually helps when people then get SARS-CoV-2 infection. This is a little bit of that associative data. So you can see here a very large study, 73 million charts that were retrospectively reviewed. They developed 2 cohorts of patients of about 37,000 persons per cohort who had received the influenza vaccine 6 months to 2 weeks prior to getting a diagnosis of COVID-19 infection. And then they looked at a variety of adverse events at 30, 60, 90, and 120 days. And that's what those figures show. So on the left-hand side are the columns of people who had not received vaccine. And the right-hand side of those columns are the folks who had been vaccinated. And you can see in every instance that at 30, 60, 90, and 120 days, the columns are much higher in those folks who had not been vaccinated with regard to the risk of sepsis, stroke, ICU admission, emergency department visit, or DVT risk. So again, this is fraught with a lot of potential confounders, but the investigators did a good job with their propensity matching and trying to control for that. Not a rigorously done sort of prospective trial, but nonetheless, one that does suggest that getting the flu vaccine will actually help you if you then later get COVID-19 infection. Now, for considerations with regard to influenza vaccine, I'm not going to go over this table in great detail. Obviously, these slides will be shared with the audience, but on the left-hand side, it goes through various sorts of patient settings, from outpatient care through various sorts of congregate living settings, et cetera. And then across the top of the chart, you can see in patients who have been fully vaccinated against COVID-19 and with no contact, if you just go down that table, it says, these are the people you want to give flu vaccine to. Now, if folks who are not fully vaccinated, but do have contact, you can vaccinate them. But what this also relates is that people should not present specifically to get influenza vaccine during that time period. Now, patients with asymptomatic or pre-symptomatic COVID-19 Same sorts of considerations. You can vaccinate, but you don't want people presenting specifically to be vaccinated. And then on the far right, people with symptomatic disease, typically we want those folks to get over their COVID-19 before we give them influenza vaccine. Here's the most recent chart from the CDC with regard to flu activity, and we're just starting to heat up in a few of the western states, as you can see, with actually New Mexico having a high rate of influenza transmission right now in the community. And then with regard to testing, very, very briefly, everybody should get tested for SARS-CoV-2 if they have symptoms. And anybody where flu testing would alter their therapeutics or what you would be doing with them clinically should also be tested. Anybody who comes into the hospital should be tested for both of those illnesses. And then for treatment, clearly we have effective treatment now for both of these conditions. People who are thought to have influenza should be started empirically on influenza treatment. Is kind of what this slide says. And then when you later exclude them from having flu, you can stop the treatment. That's kind of the bottom line of this slide. But again, it'll be in your packets that you can look at later and posted. And so I know I've probably taken up already too much time. And so I'll just end with this cartoon that we really don't want to play with these two evil twins. And hopefully we won't, but we need to prepare for both of these illnesses circulating in our community. Okay, so with that, I will stop my share and be happy to answer questions.